You're right. It's a difficult weekend to be an American and in the world stage, but appreciate the graciousness of the invitation and the chance to be here to talk with you about Mepitel film, how we've used it at Mayo Clinic. I'm going to highlight our workflows, the clinical trial, and then kind of talk about how, in my view, this fits into other strategies that we use to reduce treatment-related toxicity when it comes to breast radiation. I'll just walk you through the background and workflow, how we've implemented the film at Mayo. We'll talk about the trial, and then too much to really spend all of the time diving into toxicity reducing strategies, but I'll just give you a few selected approaches that are typically used in my practice as well. So the first part of this talk is to spend some time talking about Mepitel film, which is a skincare dressing that was originally developed for wound care. It has this safe technology. It's silicone based. It adheres without the need for additional or external adhesives. It's breathable and flexible. And it's been used in recent years for radiation dermatitis prophylaxis. Um, this is the study that really put it on the map in terms of developing our interest at Mayo Clinic. This is Dr. Hurst's work, and this was published in 2014. Essentially, in this study, or leading up to the study, there was a background of using some wound care products for radiation dermatitis, in particular Mepilex. And so Mepilex had been shown to reduce radiation dermatitis, and if you're familiar with that, it has that little bit of kind of a foam layer. And there were some studies showing reduction in dermatitis, but not a reduction in moist desquamation or more significant radiation dermatitis. And so Dr. Hurst and her colleagues wanted to evaluate whether Mepitel film was potentially or could be effective in that setting. So she included patients undergoing photon-based radiation, allowed both breast conserving therapy and mastectomy patients, and randomized patients as their own control with either medial or lateral half of their skin to be covered by the Mepitel film, and measured radiation skin reactions using both the RTOG skin toxicity measures as well as the RISRAS, which is a radiation-induced skin reaction scale that I'll be showing later because we use that scale in the Alliance trial as well. They showed a significant reduction in the radiation-induced skin reaction as measured by the RISRAS. You can see there. But especially of note or of importance was that moist desquamation rates also reduced from about a quarter to 0% with the use of the Mepitel film, which was pretty promising. At Mayo Clinic, that when that study was published, one of our trainees actually had come across the publication and brought it forward to the breast group as something that we'd be interested in studying. And as a person who's in education and as a program director, I really like to highlight the role of trainees and their enthusiasm in identifying these things and helping us really stay abreast of what's happening in the literature and identify things that are important for our patients. With that interest and with support from a faculty member, we initiated a pilot study. So this was back 10 years ago now. I'm going to show you that pilot study, but based on those promising results, we actually began to use Mepitel film and have about now 9 to 10 years of experience in addition to the clinical trial. And these are photos from our pilot study. This pilot study was supported by Dr. Ivy Peterson, who was a breast radiation oncologist at Mayo Clinic. And I would describe her practice as maybe a little bit more old school in terms of compared to today's treatment standards. I guess what I really mean is that it was standard practice for her to use bolus for all her PMRT patients and use, half a centimeter to a centimeter of daily bolus. So these were patients who were expected to get a brisk skin reaction. They applied the film to the medial half of the chest wall in 6 patients and observed a significant visible skin rash reduction in all of the patients. There was one patient out of the 6 who did not continue with participation in the study because of film non-adherence. But otherwise, the results of this visibly were promising enough for our practice to really begin to think about how could we routinely use Mepitel film for the care of our patients. So based on those initial results and feeling like with Dr. Hurst's study, as well as our pilot study, we began to talk about using Mepitel film in selected patients who we felt to be at high risk for skin reaction. But there was a lot of challenges at that time. In particular, Mepitel film is not widely available in the United States. So routine acquisition of the film was quite burdensome for us and for our patients. Many of our patients were ordering the film from overseas, and we would run into situations where the film would be, say, stuck at the border or confiscated by customs. Like you would think it was something, very high risk that patients were trying to purchase. So the cost of purchasing from overseas and shipping made the expense higher. And we also observed that there were inconsistent materials. Patients would sometimes order Mepitel 1 or other materials that weren't Mepitel film. And because the film was developed for wound care, we would get different sizes or different but similar products. We also, at that time, did not have a placement, a workforce experienced in placement or workflow. And so we had to develop nursing expertise and standardization. And so, for all of these reasons, because of these challenges, we really prioritize our post-mastectomy radiation therapy cases, and with the rationale that these patients were at higher risk of radiation dermatitis, and there were potentially greater implications for these patients in the setting of reconstruction if acute skin reaction led to consequential late effects. We discussed it with both proton and photon therapy patients, and it's important to note that this was a time in which our proton therapy practice was also starting. So we've had that practice for about 10 years, and we're also starting to treat breast cancer patients with proton therapy at that time. I'm going to take a moment to talk about proton therapy for breast cancer. This was also, so this is a photo from a paper published in 2015 looking at skin reaction with proton therapy. This is in the setting of uniform scanning protons, which is actually not the technology that we have. So we do have IMPT, and we intentionally don't prescribe full skin dose for most patients who are undergoing proton therapy. But at the time that we were integrating Mepitel film into our practice, we were also aware of recent publications or publications that were contemporary to the time that showed that proton therapy patients may have a brisk skin reaction. And we were very interested in whether the film would be of value in our proton therapy patients as well. So when we would talk about Mepitel film with patients, we especially prioritized patients we thought were at higher risk. And I collated a prospective group of patients who are treated with proton therapy, who are undergoing proton-based and post-mastectomy radiation therapy. And these slides come from PTCOG several years ago, where I presented this data. And again, with the caveats that we do modulate the skin surface dose and intentionally outside of the setting of inflammatory breast cancer are not giving full skin dose for really any patient who's undergoing post-mastectomy radiation. And in our proton therapy patients, we're also reserving that treatment for our younger patients, and that often does mean higher risk patients as well. So patients who might be getting escalated to higher than standard doses because they need internal mammary lymph node boosting, need chest wall boosts, or have bilateral treatment, for example. In this cohort of patients, we treated 20 of them were reconstructed, 13 were unreconstructed. Most patients, so 29 of 33, were able to use the film throughout the completion of radiation therapy, which, I think as it was early in our experience was actually pretty good. Of the patients who discontinued the film, we had just one who discontinued because of poor adherence of the film. We had a couple who experienced itching that they thought was related to the film, so elected to discontinue. And then one who had a rash that was outside of the treatment field as well, felt to be unrelated, but did discontinue the film as a result of that. When we assessed this was just a prospective cohort, so we didn't do anything like differentially covering the skin or have a comparison group, but we saw that that at the end of radiation therapy, about a third of patients had a grade 2 skin reaction. Most patients had a maximal skin reaction by physician report of grade 1, and there was just one grade 3. with moist exclamation. We saw that the quality of life scores between patients at baseline were not reduced post-radiation therapy. And in looking at some of the other measures that we detected, where 10 is kind of the worst score, we saw about half of patients rating itching on a 0 to 3 or very mild, and about half rating it as more significant. And about 55% of patients reporting no to mild skin reaction at the end of radiation therapy, which was, we thought pretty promising at the time. We did an example of a photo of a patient who was included in that group kind of before treatment and the last week of treatment. And then in our practice, it's often routine to acquire photographs around the peak skin reaction, which we think is, in the usually the 1 to 2 weeks after as well. So you can see that this woman's skin showed very minimal skin reaction during the radiation therapy, and even that post period of time had a very what I would consider from a physician perspective mild skin reaction for having undergone such treatment. And this is an example of the patient who had the more risk skin toxicity. And this was my patient, so I know that she was actually quite high risk for skin toxicity. And this is a patient who had unresected disease that recurred and wasn't a candidate for additional resection before starting her radiation therapy. So her total dose was actually escalated to 60 to 63 gray in an integrated way, and she was given concurrent chemotherapy. So while her skin reaction is brisk, as you can see, I think probably considerably less brisk than you might expect with these types of doses in this type of setting. And this is probably one of the more compelling anecdotes from that series of patient and from our early Mepitel film experience. This is a patient who also had very high-risk disease with an extensive tumor on the left side of her chest wall, and that there was difficulty in clearing margins. And so she actually had an integrated boost to 57 gray and 25 fractions, while the remainder of her chest wall went to 50 gray. And we used the film for her as I felt she would be at quite high risk for skin reaction. But as I recall, she did not want to have the film visible at her neckline. And so this was an area that was left uncovered, and as you can see here. And to me, what's striking as you compare the dose clouds is that the skin reaction doesn't correspond to the highest dose area, where the skin reaction is most brisk is actually along that medial aspect of her chest wall, and not the area where I've escalated the dose. And similarly, this is, about a week after finishing the radiation therapy. You can see again that the briskest area of skin reaction is actually along the area that was uncovered. You can see that moist exclamation in that region as compared to the other regions where, despite going to higher doses, the skin has remained intact. So, and for us, that anecdote was pretty compelling about the efficacy of the film for helping with the skin reaction. I'm just going to pause for a second and kind of talk about our proton-photon skin dose practice to just add a little bit of clarity to that. We have now, we didn't at that time, but we have a greater experience in treating, and we have actually compared how we typically treat our proton therapy patients compared to our photon therapy patients. And these were reported at Astro now several years ago. But we found that we don't actually observe a brisker skin reaction in our proton therapy practice compared to our photon therapy practice. So we have essentially the same rates of grade 2 and grade 3 skin reaction, whether we treat with photons or protons. We did find that certain dosimetric parameters in our plans are associated with dermatitis, including the dose to 1 cc and 10 cc's, and if there's any V105 in the plan, as well as the mean skin dose. But again, I think as practitioners, we're pleased to see that in our hands, we don't see an escalation of the skin toxicity with proton therapy. And really that kind of, I think, goes back to being intentional about how we handle the skin dose. We typically retract the CTV back from the skin surface. We designate the superficial 3 millimeters of tissue as the skin contour. And then we do, using IMPT, request coverage based on risk. In our non-high risk patients, we may aim for something like 90% of the dose. Although in the era of using less bolus in the setting of photon-based treatment, I think it's arguable that that could be even lower nowadays, whereas high-risk patients tend to receive higher dose, and we're really only requesting 100% 100% or full skin dose in the setting of inflammatory disease or skin invasion. We also set parameters around hotspots and heterogeneity. And then we have been pretty strong proponents of using a dermatitis prophylaxis approach. So we're offering Mepitel film or mometasone for most of our patients. So that's kind of how we typically handle that. We think that being prophylactic or taking that preventive skin care approach, in addition to improving quality of life, we think that there's the potential to reduce consequential late effects in the setting of reconstruction. So now, a couple of years ago, our one of our former chief resident, now out in practice, evaluated our overall reconstructive outcomes. And although they found low rates of reconstructive failure, which I think were about 7% in this series of patients that were treated, we did find that there were some factors that were associated with additional outcomes, like unplanned reoperation and infection. And when we looked, it looked like the use of Mepitel film was protective against both of those potential impacts for patients, which avoiding an infection or unplanned reoperation, I think, could meaningfully reduce the reconstructive complications for patients over time. So this, again, a signal detected in our own data in our cohorts of caring for patients. This is a cohort of a couple of hundred of patients presented now several years ago, but very nice, at least from my perspective, to see. The challenges with implementation of Mepitel film into our practice, and these slides were created with one of my nurse colleagues, and some of the biggest challenges for us in kind of bringing the film into practice from a practical perspective were initially not having a consistent time point about who is going to talk about the film and how are we going to integrate it, and then how are we going to communicate to that nurse, how are we going to educate patients, and how are we going to educate our staff. And really systematically over the years, we've addressed these concerns or these challenges. We now have the physician always bring it up to patients at the time of consultation. Our patients have a nurse visit at the time of simulation where they get some education materials that have been created. The brochure provides information about what the film is, as well as how much the nurse would estimate the patient should purchase for the initial placement and what they estimate might be needed over the course of treatment. And then we've now developed or have developed staff education to teach our new nursing staff how to place the film and what best practices are, including a film placement video, which I have included in a slide coming up, and I'll kind of show a little bit of it. But that was really important to us when the Alliance trial was starting because we use that as training material for the additional sites that were enrolling patients on the clinical trial. So it was nice to have some of these tools in place. Meanwhile, while this was all going on in terms of the workflow, we were able to establish a routine or stable supply of Mepitel film at the Mayo Clinic store. So we have attached to the hospital or within the hospital a store where patients can purchase durable medical equipment. And after we ran into challenges in the first several years of use or first couple of years of use of acquiring film for patients and some of those funny but not funny situations of having film confiscated at the border and so on, we worked to establish that. So now our patients go directly to the Mayo Clinic store and they can purchase Mepitel film right off the shelf, and they get instructions from the nurse exactly how much and what to get. And this is really just a graphical representation of what that workflow looks like and how the nurses have educated each other in terms of what happens for the use of Mepitel film in our practice. So typically, if a patient elects for film, we're placing it during the first week of radiation therapy. On the clinical trial, we had it placed before the start of radiation therapy. In our practical day-to-day workflow, usually it's placed within the first couple of days of treatment. And then nurses manage with the patient any patching or adjustments that need to be performed over the course of treatment. And in the final week of radiation therapy, the film is replaced as needed, and we provide recommendations for what to do when the film comes off in 2 weeks or so after the treatment is done. But we do typically have them keep the film on post-radiation for the first couple of weeks as well. The educational tools that we give them just describe the film as I said, and also instructions on how to prepare for applications. We want clean and dry skin, and then instructions on how to protect the film while it's in place. There's lots of questions as you can imagine about showering and things like that, and our nurses have developed some tips over the years that help patients. Things like draping a towel over the shoulder, or using a shower or barber cape or other things that kind of can help with that. The education video. I'm gonna just kind of show a little bit, and I'm happy to share with other people if they're interested. I'm gonna just turn the sound off and just kind of show you. This is really what we used to train. I'm gonna kind of get to the part where they're placing the film. Um, But this is what we use to train new nurses. And Miranda, who's my nurse, who's kind of the star of this show, is kind of narrating the placement and talking about making measurements, how to place the film, things like how much of the film should overlap, which in our practice and in the study, we say less than a centimeter or so, and how to handle the presence of an expander, because many of our patients are reconstructed. And then they also go on to share or to show placing on a flat chest wall as well. Things like replicating the patient position for treatment are things that we have found to be really helpful. So that's why the patient's lying with her arm up. When we created this video, our standard practice was conventional fractionation. In the time since that time, with the fabric data, with our own internal moderate hypofractionation study that was reported a couple of years ago at Lancet Oncology, and with the recent presentation of RT Charm, we've largely adopted moderate hypofractionation, which I think really makes it even more cost efficient for patients to undergo use of Mepitel film in terms of utilizing less of the film, which is nice. Some additional things that we've learned or that we tell patients, if patients need to, it's not our usual practice to cover the supraclavicular or neck area. We find that it's a little bit challenging for adherence in that area, and sometimes we do that if a patient is particularly concerned or we're boosting in that region, but we often just have patients use lotion in that area. And we allow them to use steroid or whatever is recommended by the physician in that area. We just ask that they keep it away from the edges. And we found that male patients, especially with the chest hair, that adherence is challenging. Patients do experience or seem to experience some itching related to the film, but they actually also experience itching related to radiation dermatitis. And so I think for most patients, this is mild, and we usually talk with patients about strategies to help with that, and sometimes recommend oral antihistamines. We have rarely encountered sensitivity to film. It doesn't happen very often at all in our experience, but it has happened a couple of times. We now pre-screen patients who have a history of skin sensitivity or adhesive allergies, and we do something that we call a patch test, where we place a small piece of the film on the skin outside of the radiation therapy field at the time of simulation. And in the week or so before starting radiation, we leave that film in place. And then the first week of treatment, we just evaluate, and if everything looks good, we move forward with placing the film. We have found that adherence of the film is challenging during times of heat, sweating, or humidity. And this is something that came up on the clinical trial as well. Sites that were experiencing those things were sometimes writing about having to change the film a little bit more often. And I think this is something that is challenging. And we're usually talking to our patients who like to get in a good workout or to sweat about whether they'll be able to maintain their usual level of physical activity and try to minimize the degree of sweating to improve with adherence. So to kind of summarize our experience, we estimate that about 80% of our post-mastectomy radiation therapy patients use Mepitel film. And that's really from my practice and another couple of the breast practitioners. And we weren't always at that high level, but we've just gotten really accustomed to using the film, and we have gotten good experience in placing it. We don't often use the Mepitel film in our intact breast population. I think think it seems to work in that population as well, and we know that from the available evidence. But in terms of clinical workflow, adherence, and gains, it's not something that's become part of our standard practice for our intact breast patients. Nevertheless, we think we've treated over 800 patients with Mepitel film, and it is usual for us now, and our nurses are accustomed to this workflow. We've been successful at our Rochester site, and so we have adopted use at our satellite facilities too. We have a number of local Midwest satellites in Minnesota and Wisconsin that also regularly use the film for patients. So that I think is a nice introduction, or I hope it's a nice introduction for the randomized clinical trial. So this is the Alliance A221803 study, which I reported as a late-breaking abstract at the San Antonio Breast Meeting just 2 months ago in December. I think it's important, or I want to note that it was several years of development. So Dr. Chow mentioned that we've been friends for the last 5 years or so, and I think we were developing or co-developing our studies around the same time, and I really appreciate the collaboration that we've had. From my perspective, it was. Interesting to see the difference in working through the trials process. The process of opening a cooperative group trial in the US takes some time and took some time. When we received approvals, we also then had to meet some FDA requirements in terms of the use of Mepitel film, as it isn't approved for the use of, it doesn't have an indication for radiation dermatitis. So we had to do some extra work to demonstrate the absence of some chemicals in the film. And the labs that could do that testing were located in Europe, and it was happening at the time of the pandemic. And so we found that there were a number of challenges in getting the study open. But with perseverance and good mentorship and great help from everyone, we were able to finally open the study in the summer of 2022. We activated across 25 sites around the country, and these are all sites, with the exception of my own site at Mayo Clinic, that did not have any prior Mepitel film experience prior to the study. So I think it's really remarkable to be able to open this kind of study and to train up at these kind of sites, and I'm really proud of that. I think it says something about the potential for a wider adoption across the United States. The other thing I included on this slide is the accrual to show that after that initial lag of activating our sites, there was a really strong patient interest in this film product, or in participating in the clinical trial. So we actually enrolled above expectation and closed early, which was really, I think, really great. So I'm going to go through the results. These are the slides that I presented at San Antonio. So again, this is Mepitel film in the setting of post-mastectomy radiation, our phase 3 randomized clinical trial. And I did not have any disclosures except for my employer. I think, on this call know the background of radiation dermatitis, that it is a common source of morbidity for patients. I hope I've shared why we think that patients who are undergoing post-mastectomy radiation therapy are at higher risk. That is observed across the clinical trials. We see that symptoms peak around the end of radiation therapy, or even in the 1 to 2 weeks after. And despite how common radiation dermatitis is, there isn't yet a universal consensus for prophylaxis or management, although I think there's certainly important work being done in this space. There's a wide variety of institutional standard of care that are used across various centers. And again, the background is that we had a strong institutional experience with using Mepitel film to reduce radiation dermatitis. This was a phase 3 randomized clinical trial with a 2-to-1 randomization, so in favor of the Mepitel film. So 2 patients with film for every 1 for institutional standard of care. Notably, we allowed for any non-dressing based institutional standard of care. So patients were allowed to be prescribed um, steroids, Strat XRT, whatever the center used as their usual recommendation. We stratified based on breast reconstruction, BMI, and the use of boost and bolus, as these factors are known to be associated with skin reactions. As I mentioned, we recruited across 25 sites, and we elected to treat in the setting of conventionally fractionated photon-based post-mastectomy radiation. It's important to note that we were developing the study at a time where that was considered the standard of care. And although moderate hypofractionation is arguably a standard of care approach, and that kind of happened while the study was open, we were accruing so well, and the differences in terms of peak endpoint or peak skin reaction for timing and so forth would have made things quite complicated in terms of amending or revising. So we really kept it at the conventionally fractionated approach. Our primary endpoint was the severity of radiation dermatitis as measured by the patient component of that RISRA scale I mentioned before. And we collected this weekly during the radiation therapy, as well as the 1 to 2 weeks after radiation to try to capture that post-radiation peak and at 3 months. We collected a number of secondary endpoints, including the combined RISRA score. We solicited certain acute adverse events using the CTCAE version 5, including radiation dermatitis, itch, and so forth. We also have secondary endpoints that are not yet ready for presentation, and I'll kind of talk about that because we're acquiring the information still. And our hypothesis was that the film would reduce the severity of dermatitis compared to institutional standard of care. This is a RISRA scale, these two tables. The top table is the patient-reported scale, and this was our primary endpoint, and it assesses tenderness, discomfort, pain, itching, burning, and the degree to which skin reaction has affected day-to-day activities, whereas the provider component is the second table, and it assesses the presence of erythema, dry desquamation, and moist desquamation, as well as necrosis. We registered 216 patients. 143 were randomized to receive Mepitel film, whereas 73 were randomized to standard of care. Of note, 8 of those patients withdrew consent prior to beginning treatment. I think probably supporting the idea that the patients were interested in the study, potentially to be able to have access to the film. The population median age was 53. About a quarter of our patients had a BMI of 25 or less, whereas about 30% were in that 25 to 29 category, and about 40% were actually in the BMI over 30 category. So reflecting kind of, I think, the change in body habitus across the country. About 2/3 of patients had undergone breast reconstruction, and about a third were planned for treatment with bolus, and about 20% had a boost as a component of their treatment. And here are the primary endpoints results you can see here. Not included on this table, but on the point, we had very high compliance with completion of the RISRA scale. So patients were really very diligent about completing the scale at each of the collected time points, and we collected a median of 8 time points per patient. You can see that the peak skin reaction is higher in the standard of care arm compared to the Mepitel film arm, and the area under curve reduction was 11.2, so significant reduction in the skin reaction. We also observed a time effect with the RISRA scores being statistically lower using Mepitel film during weeks 4, 5, and 6, and that would be if they had a boost and in the 1 to 2 weeks after radiation, which really aligns with when we expect to see a peak skin reaction. So it's nice to actually observe that that is when we see the effect of the film. Our combined RISRA scores were also statistically lower with Mepitel film. The area under the curve difference there was 16.1. And in terms of our acute solicited adverse events, there was a significant reduction in grade 2 or 3 radiation dermatitis from 44.6% to 25% in the Mepitel film arm. And importantly, I think we did not observe a significant difference in acute acneiform rash, in pruritus or itching, or skin infection. And there were no grade 4 or 5 adverse events reported and no difference in oncologic outcomes. So we were able to conclude that Mepitel film significantly reduced radiation dermatitis compared to standard of care, and these findings support the use of Mepitel film as a standard of care option for dermatitis prevention or reduction. The additional secondary endpoints that we have ongoing, we did acquire photographs of the patients. We're having blinded photographic review, and we did acquire plan information. So we'd like to compare some of the radiation plan parameters with outcomes. We also aimed to collect long-term toxicity and reconstructive outcomes as an exploratory endpoint. So we have ongoing follow-up for that as well. So that was the study. I was so pleased that we were able to be successful, especially enrolling across a variety of different geographies in the U.S. to centers that were using Mepitel film for the first time, and really immensely grateful for the mentorship and support to get the study going. In terms of how this fits in the landscape of other Mepitel film trials, I think it's pretty clear that Mepitel film is effective in reducing radiation dermatitis related to breast cancer. And there's Dr. Chow's work, of course, and additional clinical trials as well. To me, the evidence is less clear in the head and neck space, and my guess is that that has to do with really the location and film adherence, although there have been some meta-analysis that support that it may be effective there as well. And the patient experience with Mepitel film, which has been evaluated as shown below with the film, is positive. So in my view, the future, at least in the United States, in terms of how Mepitel film will be utilized across the country, is going to be influenced by the patient costs and workflow and access optimization, which I think efforts to improve access and to develop some of these optimized pathways are ongoing. And so the additional work to be done on the clinical trial, I mentioned that photographic review and long-term follow-up. We also had a correlative endpoint. We collected skin swabs for patients. It was an optional correlative endpoint, but to evaluate the influence of the skin microbiome on the development of radiation dermatitis. And then I think some additional work that will come forward, probably not in the initial publication, but that we did collect are some of the practical endpoints. So each time the film was patched or replaced, we collected how much was replaced and how much was patched to try to assess the clinic, the burden of using the film in the clinic. And again, I think in the US, really how the FDA handles Mepitel film and how patients can access it is likely to influence how it's used in the future. I'm really interested in trying to understand the potential effect of Mepitel film on the microbiome. On that first timeline I showed you, one of the studies that we've done here was a skin swab study. So this is not yet published, but this is our internal data. So not from the clinical trial, but from an internal study that we did where a portion of the chest was covered and a portion was uncovered. And interestingly, this is a graph of alpha diversity or showing the difference in species of microbiota on the skin swabs. We showed that in the pre and post radiation therapy skin swabs with Mepitel film, there were actually differences, whereas we did not observe that in uncovered skin. So I wonder if some of the effect, aside from what has been postulated in terms of reducing friction and improving the skin barrier integrity, could be related to the skin microbiome. And the film does have, I think the nanopores would be an antimicrobial or at least a barrier to some microbes. So I'm curious about that, and observing lower rates of infection, I think is kind of interesting. So I'm really looking forward to continuing to work in that space. Part of what I think is intriguing about that space is that we've seen this other data come out in the last couple of years about the role of the skin microbiome in radiation dermatitis in general. There was this decolonization paper from a couple of years ago in JAMA Oncology, where breast cancer patients who received decolonization prior to undergoing radiation therapy using both topical cleansing as well as the intranasal antibiotic had lower rates of moist desquamation. Again, it significantly reduced radiation and moist desquamation and acute radiation dermatitis scores. So I think that's interesting. And then there is or was a recent publication kind of prospectively following changes in the skin microbiome in patients undergoing breast radiation therapy, and they also observed some changes. So the microbiome is a challenging space to work in, and skin microbiome is challenging as well for lots of different reasons in terms of how the data are analyzed and how you can acquire good samples from swabs and so forth. And so I don't think it's necessarily a clear cut, but it's certainly an interesting space. So I have a couple of minutes. I'll just try to zip through a little bit of this, but Edward, you can stop me if you want to stop for questions too. I wanted to kind of put the use of Mepitel film kind of alongside other opportunities I think we have in breast radiotherapy to reduce toxicity and just kind of think about how we take care of our patients. So I'll try to zip through this. There are lots of opportunities to now personalize breast radiation therapy, and I think it's a super exciting time to practice in this space. When I was in my training, we were you always gave kind of conventional fractionation. It was almost always whole breast radiation. And we just didn't have these options to customize. I think we do such a better job of selecting our patients and right sizing the treatment, whether that's on the technical side, kind of choosing the right modality, or whether it's choosing the right volume, or shortening the course of radiation therapy, or how we support the patients. And Mepitel film, I think, falls into that supportive measures, but I think it really has a nice role to play in terms of the overall picture of optimizing care for patients. So when I think about kind of the current practice and open questions, the things that I'm doing or thinking about now is, can we extend omission of radiation therapy to certain populations that we aren't yet? Can we consider monotherapy? I have some slides on the Europa trial coming forward. Are there patients who could get partial breast radiation who we might not have thought of that before? Can we shorten the course of radiation therapy? Can we integrate boosts? Do all patients need to be boosted? And are there patients who can have omission of RNI or omission of chest wall radiation or omission of PMRT altogether? And so I'll just kind of highlight a few recent papers that I think are really interesting. The Europa trial that was presented at the same meeting and published in Lancet Oncology, evaluating exclusively endocrine therapy or exclusively radiation therapy for early stage breast cancer patients. This was just a really early follow-up of a couple hundred patients, but nicely showed no local recurrence in either arms, and reduction in health-related quality of life was significant for endocrine therapy monotherapy, but for radiation therapy, it was not statistically different than baseline, and there were fewer side effects for radiation therapy. So to me, this really highlights what we see in clinic, that partial breast radiation for older patients might be easier than endocrine therapy. And, we of course need long-term follow-up, but again, getting at trying to give just the right amount of treatment and not too much or not too little. I was the discussant for the hypo-SIB trial at Astro, and they reported a couple of years ago a reduction in acute skin toxicity with an integrated boost compared to sequential boost, and this year presented their local control data and long-term toxicity, which looked excellent. And thinking about this in context of kind of the other integrated boost data that we have, which include the import high trial and the RTOG trial, we, I think, can not only shorten financial toxicity for patients by integrating boosts when it's needed, but potentially reduce acute skin reaction. And if you look at the import high data in the standard dose arm, the 48 gray arm, potentially some of the long-term effects may be lower with an integrated boost as well. More work to be done in terms of how to adopt this into practice. But if we look at the lead-in trials for the hypo-SIB trial, some suggestion that the technique like IMRT might actually reduce fibrosis and lymphedema. So I'm really interested to see kind of the full publications of these papers coming forward. And certainly, one question that I think we ask ourselves in the clinic every day, but also when we ask it scientifically, patients really value shorter courses of radiation therapy. It is a reduction in their time commitment for treatment and financial toxicity. And this is, I think, the direction that we're moving in breast radiotherapy with ongoing trials evaluating integrated boosts in the setting of ultra hypofractionation and translating moderate hypofractionation from just whole breast to breast and nodal or to post-mastectomy, and then translating ultra-hypofractionation potentially to the post-mastectomy setting. We've done a study here at Mayo doing that, and I think there's other ongoing data as well. Just to make sure we have time for questions, I think I'm going to zip through some of this. Again, lots of progress made in taking care of breast cancer patients and personalizing our options for treatment. Other supportive things that are routine for me to discuss in practice include the use of Wisconsin ginseng, which is evidence-based to reduce cancer treatment related fatigue. This was a clinical trial published now about 12 years ago, but this is a conversation that I typically have with patients. And many find it to be valuable. We also spend a lot of time talking about exercise. I'm now increasingly considering lymphedema, prophylactic use of a sleeve for patients who are at high risk of lymphedema based on this paper showing that prophylactic use in high-risk patients may reduce risk of long-term lymphedema. We are using UV tattoos and in some patients not using tattoos. And of course, I think all of these patients should be counseled to stop smoking. So I'm just going to conclude so that I make sure that we have time for discussion. But I wanted to overall conclude that Mepitel film is effective in reducing radiation dermatitis. I think that it's really interesting and it's worthy of investigating both why patients develop radiation dermatitis and what are the factors that influence it, but also how does Mepitel film work and then that will kind of be the future of next step interventions as well. Reducing breast radiotherapy toxicity, I think, is a priority for all of us who take care of breast cancer patients. And some of that is how we support the patients, things we do like Mepitel film. Some of it is technical, like how are we giving the radiation and what we do to optimize it. And some of it is selecting the right treatment for the right patients. And then, although I zipped through the last part, I think there's lots of opportunities for us to partner with our patients to work to improve their outcomes. And I'm grateful to be somebody who is studying in this space because I think it's really meaningful, both in terms of short-term toxicity and long-term outcomes for our patients who we know have excellent survivorship. So I'm going to stop there so that we can hopefully have a few questions or discussion.
So thank you very much, Kimberly. This is a very well attended presentation, excellent presentation. At peak time, we have 69 people attending. So this is one of the highest attended. Thank you very much. And the talk is very good. So now we invite people who can put it in the chat or you can just turn on the microphone. Now I'm going to ask Dr. Jean Wright. I think, Jean, you are still here, right? So Dr. Jean Wright was at the Johns Hopkins, and she was the discussant when I presented our RCT, Canadian RCT in the ESCO plenary. So now, see, Jean has moved to another center, US, and I think that this will be a golden opportunity for Jean to summarize what you think about the Alliance study and in comparison with the Canadian study. I think that we will benefit from you. So Jean, your time.
Sure. Hi. Thanks so much for the opportunity to say a few words. So yeah, I was formerly at Johns Hopkins and I'm now at the University of North Carolina, and we're actually just in the process of thinking about implementing our practice for Mepitel here. So the timing for this was great. And also, I just want to thank you for bringing up some of these other sort of supportive considerations that we have for our patients. This is just a really excellent talk. So I think that in terms of, really applying this, I appreciated all of the comments that you made about, kind of from a practical perspective, which patients are really going to benefit, and, just practical things about how to apply it. Because I think that's, for most people, that's probably the biggest barrier is just the actual effort of, building up the program for who's going to do what and, how it's going to work to actually get this, onto the patients. So I think your point about hypofractionation, making it more accessible is great. On the other hand, I do think we're probably seeing less skin toxicity with those patients. So, you mentioned using it primarily on patients with either flat chest wall or reconstruction and less on patients with intact breast. So I think, it just comes down to sort of picking the patient population that's really at the greatest risk for skin toxicity, and then, figuring out a good program for applying to those cases. I also appreciated your comment about not applying it in the superclav area, because I think from a practical perspective, that's where we see, just so much movement and it always kind of peels and folds and that sort of a thing. but focusing on, kind of the chest wall and that higher risk area. Is really great from a practical perspective. So, my basic take home is that I do think that, we have challenges getting access to it. We have challenges putting together a program where, we really have like the bandwidth in clinic to get it onto every patient. But I think with this data, it's sort of hard not to think about implementing it for those patients that we identify to be at the highest risk. So, that's kind of my take home from it, is that we'll definitely be trying to put together a program of like who those patients are. Certainly conventional fractionation, if we're using that for whatever reason, certainly patients where we're trying to escalate skin dose for whatever reason, those are going to be the patients that benefit the most.
So thank you very much. I just want to point to the point for the supraclavicular, the regional area. Yeah, so we were told that it is an area with the poor adherence, and we agree with that. But after that, okay, in order to improve the compliance, we actually, Rosemary here, who is a nurse in Vancouver, together with the company, we produced a video to teach the patient's family member how to put on the film themselves. And surprisingly, okay, I was asking the husband, the boyfriend, to put on to the supraclavicular area, and they did so well. It adheres so well, and we actually don't see any moist desquamation in the area. So I think that the concept of the moving around in the supraclavicular area, therefore, hinder not put the film there. We actually have a lot of the patients with good results in the supraclavicular area. So number one. Number two is Kimberly's place used to nurse. Our center, our radiation therapy department led by Steve Russell as well as Sean Franson. We actually have helpers in the RCT at that time. And now they are going to implement the radiation therapist assisting, putting on the Mepitel film for the patients at the machine. So I think that, okay, the number one is the radiation therapists know the radiation area. So they will be able to, for sure, cover the area very well. Number two is, as you know, okay, for the experienced people who put on, our radiation therapy supervisor, he can put on within 5 minutes. So it will be actually very quick. So we are going to train the radiation therapist at the breast treatment unit to put that on. And it's going to see whether we will be doing it successfully. So hopefully next year we'll be able to tell you the radiation therapist lab implementation of rolling out this in the clinical practice. So again, I have to thank our radiation therapy department, Steve, Russell, and Franson, and hopefully we'll share with you our experience. So in that way, we don't actually have to bother our review nurses. So good. Okay. So any other comments from any people? Feel free to put into the chat and discuss with us.
So, Edward, I just wanted to say that I think the work that you're doing to, train caregivers is going to be really important. And if that can be successful, that may be a nice way to improve access for centers that don't have the same degree of resources that I might have here with the clinical nursing staff who are experts. Our nurses here are also trying to educate other nurses. So some of the slides that I used from Miranda were actually presented at the ONS Society last year. She had a podium presentation for that. So I think, we'll see different mechanisms for using the film, but getting at those practical things, to Dr. Wright's point, is going to be really important. So I see a couple of questions in the chat. One is about using the Mepitel film on patients with inflammatory breast cancer. We do use Mepitel film in that setting. So I think those patients are getting often full skin dose and a chest wall boost. We didn't include them in the clinical trial just because of the differences in how the radiation is usually prescribed, and those patients having some different potential for really brisk skin reactions and it complicating the picture. But in clinical practice, it works very nicely. And I think it does help avoid moist desquamation and potential treatment breaks for those patients. And then I see another question that is if we have any race ethnicity data. We did aim to achieve, I think, 20% minority accrual on the clinical trial, and we fell just short of that. I think we ended up with like 17 or 18%. So we will have that information. I don't have that data right now, but I hope to be able to provide that information in the future as well.
Great. Okay. Any other question? If not, then in view of the time, thank you very much for everybody. If there is any question, feel free to email me and I'll forward to Kimberly. So again, thank you very much, everybody, for the attending.
Fantastic presentation. Thank you.
Mhm.
Thanks, everybody.